immunohistochemistry on the slide. This is one way to do it. And or we do it using flow cytometry, using suspensions of cells. The third is cytogenetic features that we discussed, which will continue to be important in today's topic. And of course, we use molecular and genetic approaches, which also has become very important these days, especially in immature leukemic processes. For lymphomas, not so much, but for leukemias, this molecular genetic approach is very important. Okay, so immunophenotype, we discussed the two ways last time. One, doing the immunohistochemistry on the slide, and you can see that antibody that's tagged to a specific antigen with the fluoroprom, and that's how it looks under the microscope. These are Hodgkin cells expressing CD30. Or you can do it in suspensions, where you have cells in suspension, and you get antibodies that are targeting cell surface antigens. And depending on what antigen is there in the cell, you will see expression of certain markers. Like in here, you see CD19 and 34. So this population of cells in this tube happens to be positive for these markers. So that's one way you do immunophenotype. And which then begs the question, why is all of this immunophenotype really important? Why can't we just give one-shot chemotherapy now in these patients? So we will discuss some of this. As I gather, a lot of you are final MBBS here, right? How many of you are really pathology, second MBBS? Anirudh?
Around
Yeah,
20
how many of you are really, are most of you final MBBS here?
So we have 20 second year students, sir.
Okay, you have 20 of second year students and it's a mix, is it? Okay, final MBBS and second year?
Yes, sir.
Okay. Okay, so you know what, we will discuss some of the things as it relates to final MBBS students too. We discussed this last time, the definitions. What is lymphoma and what is leukemia? Yeah. So lymphoma is any solid swellings. Yeah. And leukemia is anything that comes in the blood. So we discussed lymphoma and leukemic phase, where tissue from cells from the tissue can come out into the blood. So lymphoma can circulate in the blood and be called a leukemic lymphoma. Or you can have a leukemia where it goes to the tissues and makes a solid mass, and you call that as a leukemia with lymphomatous manifestations. So any swelling is called lymphoma. Yeah. So lymphoblastic leukemia can present with lymphadenopathy. So you have to remember this very basic rule. And of course, things can present both ways, with cells in the blood and cells in solid tissues and lymph nodes. You should not have this misconception that lymphoma is always presenting in solid organs, whereas leukemia is always in the blood. So we discussed lymphoid and this myeloid. Yeah. So last week, and they can occur in blood and tissues, as we discussed, and they can be immature lymphoid or mature lymphoid. And you have lymphoma, which is lymphoid and occurs in tissues as solid lymphoid, which is what we discussed last week. So this week, we are going to discuss the immature leukemic proliferations. And the in the lymph node. This transformation occurs only in the lymph node. So the main antigen encounter for B cells occurs only in the lymph node. So this is a very busy slides, but you don't really need to know much of this. What you need to learn from this slide is the fact that all B cells start from development of a hematopoietic stem cell, which becomes a lymphoid progenitor. And it goes through multiple stages that we talk of over here. There are multiple factors that promote B cell development. And the unique thing about B cells is the ultimate goal, as we speak, is for a B cell to produce a surface immunoglobulin molecule like this. This is what an immunoglobulin molecule looks. This is how a mature B cell should look. And the immunoglobulin molecule has a heavy chain and a light chain. And the immunoglobulin molecule is usually held into the cell membrane using this molecule called CD79. This is called the tether of the immunoglobulin molecule. So the ultimate goal of every B cell is to produce a surface immunoglobulin like that. So in the process of B cell development, what happens is the genes related to the immunoglobulin molecules, the heavy chain and the light chain, they undergo rearrangements. The immunoglobulin genes are very unique because these are the only genes that actually rearrange themselves. This is not the case of one gene and one product hypothesis. Okay, this is not like your average cystic fibrosis transmembrane regulator protein, where you have one big gene and then you have one protein coming out of it. Immunoglobulin genes are not like that. They are arranged in multiple segments. But I'm not going to discuss all the segment business now because all of this is immunology and molecular biology, and that's beyond the focus of this class. So suffice it to say that in the immature B cells, you will not find the functional surface immunoglobulin molecule. Whereas in mature lymphoid proliferations that come out of the bone marrow, every B cell will have an surface immunoglobulin molecule. So this is the basis, as you will understand in subsequent slides, for the use of flow cytometry in diagnosis. So here, in the immature stages, B cells need these kinds of enzymes called terminal deoxynucleotide transferase and things like that. So these are important proteins that are required in the nucleus of the B cell in the development. And one more important molecule you should remember for B cells is Pax5. It's very important for B cell development. Okay, forget all of this that's written on this slide. This is not necessary. This is just immunology and how this process of how Pax5 really helps in this situation. So remember Pax5 and remember TDT from this slide. Yeah, because these are relevant for you for diagnosis. So the basic things we need to know here and why. One, B cells develop in the bone marrow. They come in the blood and they go to the mature lymphoid tissues, which is the lymph node. So immature lymphoid processes evolve in the bone marrow. So ALL, that is BALL, when it develops, typically that's why they do a bone marrow biopsy. They don't go around poking inside lymph nodes to look for B lymphoblastic. And they do circulate in the blood. So sometimes if you do a peripheral smear and look at it, you will be able to see the blast circulating in the blood. And so immature B cells don't express surface light chains. Light chains as in light chains of the immunoglobulin molecule. And I told you that immunoglobulin molecule is made of heavy and light chains. And we test for light chain expression by flow cytometry. So that's why this feature is very diagnostically useful in flow cytometric diagnosis of B lymphoid processes. And one more thing that you should remember is the distinction of mature B cell from immature is very critical therapeutically. And why is this important? Because the therapy and the toxicity profiles of the drugs used for mature lymphoid proliferations versus immature are very different. And the relapse patterns of the disease itself is very different for both. Like for lymphomas, let's say a patient has a mature diffuse large B-cell lymphoma, like we discussed last time. Do any of the final MBBS know what therapy we give for diffuse large B-cell lymphoma upfront? Feel free to do it in the chat or tell it orally if you want to, and mute yourself. You've all done pharmacology and some medicine and oncology, right? Final MBBS. Let's see. Okay, nobody's talking. I can't hear you. Okay, you know what? I'm going to continue. I can't hear you anyway. So okay, for mature B cell processes, typically they give CHOP-R. So hopefully you know what CHOP-R is, right? R is rituximab and CHOP is part of the chemotherapy that we will not discuss right now. So anyway, that said, B lymphoblastic, we are starting with B because you know that there's a B and there's a T, lymphoblastic. And so B lymphoblastic is about 0.4% of all new cancers in the adults and kids. And when you consider only patients who are less than 20, it's nearly like half of all the cancers. And within the blastic processes, if something were to present in tissues, T lymphoblastic is much more likely to be a tissue-based presentation, whereas B is more likely to be the bone marrow and leukemia. So that's one thing to remember. So now this is a big list that some of you might need to know. For only PG students probably need to know this big list, but I will touch upon some of the entities in this list that we call as BALL. So whenever a patient has blasts in the blood and you prove that it is B lymphoblastic, there are some things that we look for from genetic perspectives. One, either we call it as a BALL NOS, not otherwise specified, and there are some BALL subtypes that are very recurrent and occur in certain ages. And this is the big laundry list. And 3 are kind of important to know, especially in the current day and age. One, the BCR-ABL one. You've heard of BCR-ABL. Do you know where else BCR-ABL will occur? Translocation? Anybody? Where do you have the BCR-ABL translocation? Come on, it's okay. Somebody tell. Chat? Okay, chat is disabled. Okay, never mind.
CML, sir.
Finally, CML, somebody is talking. Okay, BCR-ABL occurs in CML. Yeah, so the same translocation can occur over here, actually. But the translocation occurs in not a myeloid stem cell, but it occurs in an early lymphoid stem cell. So when that happens, the genetics are different and it produces B lymphoblastic. It's strange, right? The same translocation can occur in a totally different cell and produce a totally different phenotype. Ultimately, it's an advantage of proliferation. That's what's happening here because of the tyrosine kinase. And of course, there are some bad players like MLL. MLL gene is another, it's on 11, chromosome 11, and it's a bad player. If you have MLL translocations, it's bad. And MLL can partner with a lot of other genes. We will not get into the partners of MLL here, but suffice it to know that this is a big list. And one more that is relevant in the current day and age is this number 8 that I've highlighted called BCR-ABL1-like. So the latest WHO touches upon this BCR-ABL-like. Yeah, and we will discuss some of this in the next slide and what is more common in what age. So there is a definite pattern to all of that that you should know. This big list, I will give you some references later. You don't need to make a note of all this, nor do you need to remember this by heart. Okay, so don't even make an effort trying to remember things by heart. So this is a graph showing, this is a vertical plot stratified by age in patients who are less than 1 to 19, and more than 19, and the percentages of each subtype of genetics that it represents. So when you look at patients who are less than 1 and develop lymphoblastic leukemia, you can generally predict the genetics most of the time. And you can see that a substantial proportion of patients actually have the yellow, which is the 411. And as you know, the 11 involves the MLL gene. And the other purple group represents other MLL. So big proportion of congenital lymphoblastic, B lymphoblastic leukemia is very predictable and is related to MLL. So that's one thing you should remember. Next, when you move to the second age group, teenagers, you can see that the orange is a big component of teenagers. And orange is actually a group called hyperdiploidy, where you have extra copies of multiple chromosomes. It sounds like it should be a bad thing, right? Hyperdiploidy. But in reality, no. Actually, it's good, hyperdiploidy. The more the chromosomes, the prognosis is actually better. So that's very common in younger children and teenagers. And of course, you have this 12-21 translocation, which is also a good player in in a BALL. So these are very predictable patterns that you will observe based on the age of the patient. Last but not the least, you have pH positive BALL, okay, which is this violet or whatever color that is. Yeah, and remember this orange was pH, orange was this, and then this was this, and you would see that pH positive ALL is a big component of the older people, and pH is generally bad, but the good thing about pH positive BALL is this will also respond to addition of imatinib, which is tyrosine kinase inhibitor used for CML therapy. So these are the genetics that you should remember. Okay, PG students, this is the karyotype of a patient with ALL. Can you, any of you tell me what abnormality this is? (652). Okay, anybody, quick. Of all the abnormalities we looked at. What is it that we see here? Everybody is keeping quiet. Okay, I think you'll have to call out someone here. Okay, Niraimuri, are you there? Okay, nobody's going to answer me now. Okay, how many copies of chromosome 1 are there? Normally we have 23 pairs, right? Okay, fine, I guess I'll talk. So this is basically hyperdiploidy, right? There's too many copies of chromosome 1, 2, there are like 4 copies of literally everything. So this is hyperdiploidy. This is good prognosis. So that's that. And what else? Let's keep going. So the step 1, you have to look at the CBC in these patients. Okay, based on this CBC, hemoglobin is 8 gram per deciliter, white count is 109 per 1000 per microliter, and platelet count is 18,000 per microliter. Okay, is this normal or abnormal? Anybody? Vignesh, you think this is normal or abnormal?
So abnormal.
Okay, that's abnormal. Why is it abnormal?
WBC is 1 lakh count.
Okay, that's too high, right? So very good. Hemoglobin, that's normal for the kid.
So mild anemia is there, 8.
Yeah, it's actually good anemia actually. Okay, platelet count of 18,000, normal, abnormal?
Platelet count abnormal.
Low or high? Is it low platelets or high platelets?
So low platelets.
Yeah, be quick, otherwise we won't finish this class. Okay, so these are abnormal. All of them are actually abnormal. Yeah, super high white count and low hemoglobin and platelets. So this you should be able to recognize when the when the CBC values come. But obviously you don't have a differential count. That's important, right? So you need to know why the white count is high. Maybe it's just sepsis. Maybe it's all a bunch of neutrophils. So you need to know the differential count before you make the next move. Okay, this is the differential count. Neutrophils, lymphocytes, and other. Okay, so, okay, Priyadarshini, is this abnormal or normal?
So newt counts are low, sir. Only 70% should be normal newt count.
Good, yeah. And so there is 93% other. What's your next step? Let's say you get this report back. What's your next step and what's your next question?
So eosinophil or
Why do you care about eosinophils? What is the next question we have? Or what do you want rather? This is the report you'll get. In real life, if you are an internal medicine physician, this is the report you'll get back from the lab at first. And you have to call back the lab and ask for more things. What are you going to ask the lab? Let's say you're there. Very practical things, nothing complicated. This is just regular. Okay, I'm going to find another person here. Okay, let's keep looking. Because I'm not going to finish this class on time. I know that. So we will take this up next time. But okay, Ashwati Varghese, are you there?
Yes, sir.
Okay, what is your next question for the lab? You get these numbers back for the differential count, and you see 93% other. What's your next question?
Maybe a bone marrow biopsy. Can we ask for that?
That's a reasonable thought. That's a very reasonable thought to ask for a bone marrow biopsy. But can you, let's say this is a 2-year-old kid, and the mother is very angry with you saying that I don't want to subject my child to a bone marrow biopsy and poke the bone. Can you get to a diagnosis without that or no?
I'm sorry, sir. I do not know.
Okay. Anybody else? Akshaya, TV. What is the third thing you could do? Look at the smear, right?
Yes, sir.
Easy enough, right? If they say other, you never know what the other is unless you look at.
Look for RBC count and
Why does the RBC matter? Differential is only for the white cell counts. So you think you'll find something abnormal in the RBC or the WBC?
WBC.
WBC. Yeah, you cannot have a WBC of 1 lakh and have 93% WBCs that are other and expect to find abnormalities in the red cells. Okay, so obvious thing is looking at the other cells. Strangely enough, more than half the clinicians, even in the US, who are doing internal medicine, don't realize that looking at the smear is probably the cheapest and easiest way to get to a diagnosis sometimes. They quickly call the team, hem-onc team, and say, go do a bone marrow biopsy. You know, you don't need a bone marrow biopsy every single time to get to a diagnosis. So the first step is you should know to distinguish a lymphocyte from a blast. Okay, so that's a very critical step. And it's good to learn regardless of what science you do at the end of the day. So let's say we saw the smear in this patient. Are these blasts or lymphocytes or neutrophils? If I give you a choice, what are you going to say? Shreya Jaishankar. Shreya?
Yes, sir.
Yeah, if you're given a choice about blast, lymphocytes, or neutrophils, what do you think you might pick in this?
Lymphocytes, sir.
Very good. These are indeed lymphocytes. These are not blasts, right? So you should be able to pick out lymphocyte from a blast easily. Yeah, and obviously we are not chatting right now. We are talking, so which is good. So now in this peripheral smear, I have put an arrow on one cell. Okay. So what do you think that arrowed cell might be, Anirudh?
Lymphocytes, sir.
Very good. So now that's a lymphocyte. So every time you look at a smear, look properly and establish which is your lymphocyte. So once you know your lymphocyte, you should be able to categorize the other cells here. Right? So what are the other cells now? Any idea?
Blasts.
Blasts. Those are blasts. Very good. So compared to the lymphocyte, the blasts are nearly 2 times the size over here. And the blast chromatin is kind of more open. What pathologists call openness, it's less black. It's more purple compared to the lymphocyte, which was much more black inside of it. So this is how you recognize blast from lymphocyte. So this is the 101 of looking at a smear. And you should be able to make this distinction regardless. And now on switching gears, I'll tell you, these are cells here that the technician would count. This is a 15-year-old kid who came with fevers, and these cells are floating around in the blood. Yeah, these cells and these cells, they look monstrous. And this cell. Any idea, Ashwati, what the cell is that I'm pointing? This cell?
Neutrophils.
Not
It's
neutrophil.
a hairy cell, sir.
That's a very good thought. That's a very good thought. It's a very hairy looking cell. But again, hairy cells don't usually circulate in young people who are 15. Right? It's an old people disease. And it's very predictably old people. And hairy cells can be confused with these normal cells in the blood. It's one of the normal cells that you see in the blood, this cell. What cell is this? What are the cells that can circulate in the blood?
Macrophages.
Macrophages.
Okay, you use it. It's a right term, but the wrong location.
Monocytes, sir.
Monocyte.
Monocyte, yes. Yeah. Monocytes circulate in the blood. Macrophages don't circulate in the blood. Macrophages are in the tissues, but they are part of the monocyte macrophage system. Okay, so it's very good. This is a monocyte. And what do you think these cells are? That explains why the patient has fevers. These are really ugly looking cells, right? They have huge abundant cytoplasm. And these were called blasts or other by the tech when they counted. But you are looking at the smear and you are the one who has to make the connection between the age, the fevers, and these circulating abnormal cells that turned out to be T cells. Shweta Muthu, any idea?
No, sir, not really.
Okay, I will give you a small clue. Monospot test was positive.
Uh,
What am I talking? Where do you do monospot test? Neutrophil antibodies.
Not sure, sir.
EBV.
Sure.
Infectious mononucleosis.
Very good. Who was that?
Anirudh, sir.
Very good, Anirudh. Yeah. So this is infectious mononucleosis. This is a pitfall for the technicians in the lab who are doing differential counts sometimes, and they will call these large abnormal cells, which are just basically T cells reacting to the virus, and they'll look like blasts sometimes, and they'll put them under other, and you will be struggling and scratching your head to see why they're calling it other. And so the patient is 15 and you see these kinds of other in a normal platelet count, then you have to think of mono. Mono is pretty common. So you have to remember. Yeah, okay, with that said, okay, we come to the BALL, bone marrow biopsy. So let's look at a biopsy here and try to recognize some of the cells, okay? Off the bat, I can tell you there are sheets of cells, there are monomorphic cells, there are blastic cells, and all this I can tell you. But it's good to learn some of the cells that you see as you recognize some of these. Any idea what this cell is? Yogita? That pink looking cell. I know it must be tough, but you can take a guess.
Not much, sir.
That's fine. I want to pass it to Lachimi. Anybody else? Okay. Anirudh, what cell is that? This is a normal cell in the blood.
Eosinophil, sir.
Very good. Eosinophil. Who was that? That's good. That's an eosinophil. Very good. So next, continuing. Now these are your lymphoblasts. And you can see that there's tons of lymphoblasts in this biopsy percolating throughout the bone marrow biopsy. And this, what are these rounded structures? that you see here, empty spaces with nothing in them. What are they? Any idea?
Fat.
Okay, fat. So that's good. And this is the biggest cell in the bone marrow. What cell would that be? Sweta and Nityashree?
A stem cell.
Sorry?
Hematopoietic stem cell.
No, stem cell won't be this big. This thing makes platelets. What cell is this?
Megakaryocyte.
Yeah.
Exactly.
It's strange that the smallest cell in the blood, which is the platelet, is made by the biggest cell in the bone marrow biopsy. Okay, so that's a way to remember things sometimes. So this is the megakaryocyte, indeed. Yeah, so you should be able to recognize megakaryocyte, eosinophil. You know your blasts. Now, other cells we don't need to know now. Okay, this is a very cellular marrow with sheets of lymphoblasts and markedly decreased normal hematopoiesis. There's one eosinophil, one more eosinophil, tons of blasts. And this is the same case with mitosis. This is mitosis. That's how it looks. It looks ugly, whatever this is. Yeah, this can't be good. And now in this bone marrow aspirate, what I saw was a core biopsy. This thing, it gives you a piece of information here, whereas this bone marrow aspirate shows you the actual cells separately. And this is your classic bone marrow aspirate smear. And you can see separate blasts, sheets of blasts. It looks kind of exactly like the blood. Okay, so it doesn't give you any more information than what you can see from the peripheral blood. This is a special stain called MPO. Anybody know what MPO is? This is a short form.
Myeloperoxidase.
Very good. This is a very simple, easy, cheap stain to do. And it takes 5 minutes, just dipping in 2 solutions. And if you are able to go to the lab in the middle of the night, it's a stain that's worth knowing to do, even if you're not a pathologist, because it can make a big difference in certain leukemias. And this is a normal neutrophil on myeloperoxidase. And myeloperoxidase will stain myeloid cells or neutrophils. So any cell that has these granules of myeloperoxidase is probably a myeloid cell. And you want to know if the blasts are myeloid or lymphoid. And to know that, a quick myeloperoxidase cytochemistry is useful in distinguishing this process. So these are your blasts. So are these blasts positive for MPO or negative? Anybody?
Negative.
Yeah, they are negative. Yeah, so these blasts are negative. And that happens to be it's not an easy cell, but that's a nucleated red cell. That's how it looks. Okay, so what we know so far, this hypercellular marrow extensively involved by sheets of lymphoblasts that are MPO negative. We still need to know some other things. We need to know the lineage, whether it's B or T. Yeah, that's important for us. And that also matters for therapy. So not only do you need to know if it's myeloid or lymphoid, but you also need to know if it is within lymphoid, it's B or T. And if it's mature or immature, we still have not proven that these are immature proliferations, right? We could see morphologically that they look immature because they are blasts, but you have not really proven by markers that they are indeed immature and lack surface light chains. So flow cytometry is critical for this knowledge. So when you do flow cytometry, what you do is you look for the lineage specific markers, B lineage, T lineage, myeloid lineage. For B lineage, CD19 is lineage defining. For T lineage, cytoplasmic 3 is defining. Whereas for myeloid lineage, we did the cytochemistry business, cytochemistry for MPO, which is actually a very good way of looking for MPO. Now you can also look for myeloperoxidase by flow cytometry. That's one more means, which is also equally good, but cytochemistry is probably a much more robust technique to rely on. And it talks about the active enzyme when you look at cytochemistry. Whereas when you look at flow, you're just looking for the antigen and not really the enzyme, active enzyme. CD19 and CD22 are both B lineage markers. 19 is very relevant, and especially these days when patients relapse, they give therapy that's based on anti-CD19. So you have to know the 19 expression level in B lymphoblasts. It's relevant for CAR T cell therapy, it's relevant for when they give anti-CD19 antibody, which is blinatumomab. If you like long names, this is one of them. And 22 is also important because they give it at relapse, anti-CD22. And that is inotuzumab is one of them that they give. So you should remember some of these therapies that are relevant for relapse and why we test for these markers. Okay, it's not only to identify the lineage, but also for therapy targets. So sometimes at relapse, all they want to know is targets for therapy. They don't even want to know the lineage, whether it's myeloid or lymphoid. They just want to know what targets are there, how can I treat. So this flow we discussed, it's single cell suspensions tagged with fluorochrome conjugated antibodies that will pick cell surface antigens. Yeah, so you should know these basic markers at least. There's a slew of other markers, but for your level, you don't really need these. But PE should certainly know some of these markers. Yeah, maturity and the maturity status. So lineage we define on this. For maturity, you need to use 3 markers, which is CD34, TDT, and CD1A. Yeah, so let's see how we are on time. Okay, 7:12. I'm going to discuss for another 10 minutes maybe, and then we'll give a break. We've been going on. So we are going to discuss a little flow cytometry over here. Okay, this is little advanced, but it's worth knowing. Not for UG level, but certainly for PG level. But I will teach you the very basics of flow. So even when you go and look at flow, you will know how to recognize things. The backbone of every flow cytometry analysis is we do an X and Y axis and look at things. So all hematopoietic cells that are mature will express CD45 to a varying extent. CD45 is the same as leukocyte common antigen. Yeah, this is CD45, and this cluster that you see here are your normal lymphocytes. And lymphocytes have very little cytoplasm, and so anything that has very little cytoplasm will have low site scatter. So site scatter is a characteristic of cytoplasmic complexity. So in the blood, compared to lymphocytes, monocytes have more cytoplasm. And so that's why monocytes will figure slightly higher on the site scatter axis. So that's how they look. And you know that neutrophils have a lot of granules. And so this is how neutrophils look on the 45 site scatter plot. So now you see these extra clusters that kind of catch your eye. These are 45 negative. These are a little more 45. These are even more 45. So all these kinds of clusters we are seeing here. Yeah. So now usually when we look at flow, we can look at any of these clusters and see what other markers these clusters are expressing. So now what we did here is to look at the cells in the red cluster. We circle this and we look at this cluster for 34 and 19. And when we do that, there's a big cluster that's positive for 19 and 34, like this. So what does 19 prove? That it is what lineage? Yogita or Shweta?
Lymphoid lineage.
Lymphoid is correct, but beyond lymphoid, what does 19 help?
B cell.
B cell.
And what does 34 tell you?
Maturity of this.
Is it mature or immature? 34.
Mature.
No. It's opposite. 34 means it's immature.
Okay.
So it's an immature B lymphoid cluster. So that itself means it's B lymphoblastic. Yeah. And there are these normal 34s, which are normal myeloblasts. You have to remember that just because there are 34s in the marrow doesn't mean all 34s are B lymphoid. You will have normal maturing myeloblasts, which are 34 positive, but 19 negative also in the bone marrow. You have to be careful about that. But the problem is, normal B cells also develop in the marrow, and immature B cells can also be mixed with cancerous B cells. So normal B cells will also express 19, and immature B cells will also express 19. So how are you going to distinguish the two of them when you mix both the bad guys and good guys in one tube? So that's sometimes a challenge for us. And so there are things that we look for that you can use to distinguish normal from abnormal. So this is a typical phenotype of BALL. It's positive for 19 and it's positive for 79A. 79A, as I discussed, was the tether molecule that holds the surface immunoglobulin molecule on the B cell. The immature lymphoid proliferations express this tether, but they won't express surface immunoglobulin. And immature B lymphoid processes will express 34 and TDT. And additional qualifying markers are things like CD10, which is positive in the common type of BALL, which is the most common type. And when they are 10 negative, they sometimes will express this abnormal myeloid marker called CD15. And when that's present, we immediately think this could possibly be an MLL rearrangement. And MLL rearranged leukemias, as you know, is very common in congenital peripheroblastics. And it's a bad player. Everything with MLL is bad. And MLL rearrangements are very notorious because at relapse, patients who have MLL rearranged leukemias can suddenly turn from B lymphoid to myeloid. So there's a plasticity that can occur in the phenotype. So that's beyond your scope, but remember, there can be other kinds of diseases. Sometimes we will also look for CRLF2, which is a marker that is a surrogate for PH-like genetic signature in young adults. We can do that by flow. So that's one more thing you can potentially ask the lab. So here we see 19 versus 34. There's a big red cluster, which is your blasts. And this is your 19 positive normal B cells in blue and yellow or orange, whatever that color is. And you can see that they don't really express that kind of 34. And the blasts have dim 19 relative to the normal B cells, and they express 34 compared to the normal B cells. And this is an immunohistochemistry, and this is a nuclear antigen that we look for, and that's actually TDT, immunohistochemistry. And here I'm showing you normal and leukemic cells mixed together. Yeah, we are 718. Okay, we still have some time. So this is the red is the abnormal, which is bright 10, and the normal B cells are this blue and orange. So there is this pattern that you'll always see when you look at 20 versus 10. There's normal B cells mature and acquire 20, whereas the abnormal ones are stuck in this phase. And this is again 38 versus 58, and these are abnormal blasts. This is the normal. So based on these patterns, we can distinguish normal from abnormal. So you should know that in the marrow, you can have normal and abnormal B cells. So when you go down and talk to the pathologist, you should be able to say, are there hematogones in this case? Hematogones are normal maturing B cells. And are they mixed in with the leukemic B lymphoid cells? So now I threw a term called hematogones, which are normal marrow immature B cells. Okay, so there are two slides here, one to the left and one to the right. And the one to the right, this is actually your hematogones. Okay, these are small, medium, large hematogones stuck in this bone marrow of a kid. These are normal B cells. Sometimes hematogones will look like leukemic B cells. In contrast, this is also taken the same cover, but these are B lymphoid blasts. So see the contrast? They are all almost the same size. They look large, whereas hematogones kind of look like lymphocytes, but they're slightly larger than lymphocytes, even though they look blasty. So you should be able to distinguish this, especially the PGs, when they look at heme path, they should know to distinguish these things. So these are special variants of BALL. This is one with 514 translocation. Okay, this is a very unusual BALL. But the odd thing about this one is it can present with eosinopedia like this, numerous eosinophils. So you know how to recognize eosinophils, and you can barely see the blasts. I can see something here that looks like blasts, but I can't really make out much. And when you do a CD34, which is a marker of immaturity, there's numerous 34s in this bone marrow biopsy indicating that this is B lymphoid leukemia. And often it's oligoblastic. You will not see many blasts, but you will see the eosinophils sometimes. And if you see this translocation, you should call it ALL, even though you don't have 20% blasts. So this is CRLF2. This is the flow cytometry, and this is another way of a histogram way of showing CRLF2 expression in the B lymphoid blasts. And this is your background normal T cells without CRLF2. And this is important to know in the current day and age. The latest WHO iteration added this entity. And there's a lot on the biology of this that we know of more recently these days. And they do respond to tyrosine kinase inhibitors and added in induction, BCR-ABL likes. So next we will switch gears and move to T cell development. I'm going to do it for another 4 minutes and then I'm going to stop at that. And we will try to continue some of this in a separate lecture because I have a lot of unknown slides. So the 101 for T cell is, T cell lineage defining marker is CD3. And all T cells that are mature should express same amount of 2, 5, and 7. T cells can only be either CD4 or CD8. They cannot have both molecules at the same time. There's a reason. And maturing T cells usually express markers like TDP34 or CD1A. And CD1A, all of this happens in thymus. Normal maturing T cells usually are negative for both 4 and 8. And at one point in their maturation, they express double 4 and 8. And after they mature further into proper T cells, they are either CD4 or CD8. So the T cell biology and maturation is part of immunology. We won't discuss much of that. But suffice it to know that even in immature T cells, CD7 is expressed uniformly in all the stages of T cell maturation. So normal maturing thymic T cells and lymphoblastic kind of sound very similar. And so you should know how to distinguish the two, especially for hematopathology. It's a big pitfall. And sometimes patients with thymoma, they will go and do flow cytometry, thinking of lymphoblastic. And sometimes people have called thymomas as T lymphoblastic. And therapy is very different for both processes. For TALL, they frequently present with mediastinal mass. There is no blood, there is no marrow involvement. So don't go chasing the blood or bone marrow, because the precursor T cells come out of the bone marrow and they quickly go to the thymus. And they develop in the thymus typically. And that's why T lymphoblastic develops in the thymus and with the mediastinal mass. Yeah, so this is cytoplasmic 3 and TDT. Both of them are positive, indicating that they are immature T lymphoid proliferation. This is a uniform population. And you can see that this is uniform CD7 over here on the 34s. This can never be normal. So this is your typical T lymphoblastic phenotype. And again, normal CD3 T cells will express either 4 or CD8. Now this T lymphoblastic is negative for both 4 and 8, as you can see over here. This is your normal CD4 T cells over here in the background. These are your normal CD8 T cells in the background. So when you see this compare and contrast on the same plots, that's very useful to know that you have an abnormal population right there. So unknown case. Okay, so let's do one unknown case. And this case was actually came in the Children's Hospital locally, and Dr. Shunyu Gong gave me this case. This is a 3-year-old boy who had a firm subcutaneous nodule on the right side of his neck. And it was measuring 4 centimeters in dimension. And the mom noted this nodule 6 weeks ago, and it was slowly growing. He was otherwise asymptomatic. CBC was normal, and a biopsy was performed. And that's how the biopsy looks. Okay, so that's the epidermis on the top, and you have the dermis at the bottom. It's a punch biopsy or a shave biopsy? Anybody can tell me?
Seems like punch biopsies.
Yeah, it's a nice punch biopsy. Yeah, so they did a punch, and the dermis is very busy with a lot of cells. Yeah, and at hyper you can see that there's a monotonous population of cells, numerous cells that it's very hard to say what these cells are. You can't just look at these cells and say, but you can say that they kind of look lymphoid. And I don't know if they're mature lymphoid or immature lymphoid. Maybe they are lymphoid. That's all I can say. And this is CD20. and this is CD3. Okay, what does CD20 mark? Anybody?
B cell.
Sorry? B, very good. So B cell marker positive. This is 79A and CD10. So what does that help? What does CD79A mark?
The
So
surface
pre B
image
cell.
header.
Tether, very good, very good. Yeah, it marks the tether of the immunoglobulin. So it's indeed one more evidence that this is probably a B cell process. And CD10 is a qualifying marker for B lymphoid processes. And this is positive for these two markers. What does this mean?
Immature B cells.
Okay, very good. So what's the diagnosis? What AL?
BALL.
B, yeah, you have to qualify the lineage. So it's BALL, okay? And on cytogenetics, there was this funny translocation called dicentric MIND20 translocation, which is associated with poor prognosis in BALL, okay? So one thing to remember is BALL does not always have to be a bone marrow presentation or a blood presentation. Sometimes you can have it in the tissue, and you have to be ready to diagnose it, even in those cases. And in this case, we did not do flow cytometry. We did immunohistochemistry, which is very easy. And you have to remember that. And it's a very common cutaneous process. So with that said, I think I am going to stop. We have only 3 minutes, and I'll give you guys a break. And we will probably take up more cases in the subsequent sessions, some unknown cases. So that way, we will continue all of this a little later. I still need to discuss mature lymphoid processes, which we will discuss later. Yeah? So I think I'll stop with that. Any questions, students?
No, sir.
No, right? So the mature lymphoid proliferations are CLL and other leukemic mature lymphoid things that we will discuss down the line in a different class when we have time. Okay? So otherwise, if I start telling a bunch of entities, you'll get bored. Okay? Bye-bye.
Thank you, sir.
Thank you, sir.